Welcome to the Head and Neck Cancer 2020 video series, presented by St Vincent's Hospital Sydney, the Kinghorn Cancer Centre and St Vincent's Private Hospital Sydney. Aboriginal and Torres Strait Islander, patients, family and community, with Associate Professor Kelvin Kong.
Hello, my name's McCrossin and welcome to this video looking at head and neck cancer and the Aboriginal and Torres Strait Islander community. This is part of a series of videos on head and neck cancer, innovations to improve survival and quality of life. And they're hosted by St Vincent's Hospital Sydney and the Kinghorn Cancer Centre. And we're broadcasting to you today on the land of the Gadigal people of the Eora Nation. We're in Darlinghurst. And I'm thrilled to be connecting to Associate Professor Kelvin Kong in Newcastle. Welcome to this program, Kelvin.
Thank you so much for having me. And I acknowledge that I'm on the Wabakal land in Newcastle, in our beautiful new centre here, which is located on a building that we've called Konara, which is related to community gatherings and being together. So it's wonderful to be here today.
Fantastic. And can you introduce yourself to the audience and give them a sort of a snapshot overview of the sort of work you do as a surgeon, a paediatric and adult otolaryngologist? Is that how you pronounce it?
Fancy words for that. I should also just quickly say thank you to St Vincent's for having me on their video, being all the way in Newcastle. But my training route started in St Vincent's Hospital. So to Professor Gallagher and the team, thank you so much for having me on board, and it's a pleasure to be here. I am an ear, nose and throat surgeon, which is probably the easy way to talk about it rather than anything fancy. And I'm really privileged and humbled to be able to work in a very diverse practice which looks at hearing, implantation, babies and breathing troubles, and obviously for this conversation, importantly, head and neck cancer operations. It's a big part of our head and neck cancer journey. I think it's something that we underestimate the impact of. I grew up on Worimi land. I'm a Worimi man, a proud Worimi man, and being on a Wabakal country allows me the privilege to look after a greater set of our population, not just in this area, but the greater Western New South Wales and greater Northern New South Wales, all the beautiful lands that it incorporates, to be part of their lives and to be part sharing that and helping their world is very lucky.
And Kelvin, may I ask, what proportion of your work would be head and neck cancer patients?
It varies so much, and I must confess I've tapered off a little bit more recently because I've been doing a lot more hearing stuff. But probably about 25% of the work that we do here presents with head and neck cancer. And that starts at a very early stage, an early diagnosis stage, right through the operative intervention. We have quite a big head and neck unit in Newcastle and headed up by the ENT surgeon with Dr. Robert Eisenberg and Dr. Darren Cope, which is a fabulous unit, and Dr. Johnson Hong, of course, which is a reconstructive unit as well. So we're seeing quite a lot. It's a very diverse population. And the kind of mix we get is one of those unusual parts in Australia because we're considered an urban population in Newcastle, but we also look after regional New South Wales and also remote New South Wales. So we're covering all parts of Australia. And I think one of the conversations in cancer, particularly with our Aboriginal population, is that diversity of the landscape that we look after and how we need to change our management paradigms to make sure we cater for the relative community that we're dealing with.
Well, it's those changes in management paradigms I think I want to ask you about. But can I just say quickly, at the beginning of each of these videos we've made for this video series for World Head and Neck Cancer Day, on the 27th of July, I've said that Aboriginal and Torres Strait Islander people are disproportionately represented with head and neck cancer patients. And I went on to the Australian Institute of Health and Welfare website, and I just thought I'd quote a couple of figures to help our audience with that. For the total Australian population, in 2019, there were just over 5,200 head and neck cancer diagnoses. So 5,200. And the survival rate for 5 years for non-Aboriginal people was 71%. And the survival rate for 5 years for Indigenous Australians was 42%. So a very significant lower rate of survival. The other thing I thought I'd just say, if I give people the numbers, is there's a big difference between the rate of head and neck cancer for men and women. So for the whole of the population, there were just over 3,800 men had head and neck cancer in 2019, just over 1,400 women had head and neck cancer, and of both the men and the women, nearly 1,300 were Indigenous people. So it's a very significant extra number of people who are Aboriginal and Torres Strait Islander get this cancer, and they survive less. Why is that so?
I think it's a really interesting and very sobering for me to hear the realities of some of those statistics. Obviously, you know those kind of statistics happen, but the reality of that is that represents family members, that represents fathers, it represents mothers, cousins, uncles, aunties. And what's really hard in taking all that in is I still think in the medical world we are fixated on a medical fix or a treatment paradigm which focuses on disease. And I really think we need to move away from that to look after how we actually treat the patient. And there are so many different components that which I'm very happy to break down. The first part of that is how do we actually get access to the care that we need? When you look at those statistics that you speak of and we break them down, it's not only that there's a higher rate, it's that the diagnosis is often at a later stage. And if you have the same diagnosis stage and you're non-Indigenous versus Aboriginal, then your treatment options are varied. And that's an implicit bias that we have in terms of how we're treating and managing those things, which can be geographical or it can be racial in nature that we're not really aware of. And so I think there needs to be a lot more work around what that data set looks like and how we actually tease out those stats. But importantly, I think, and it's probably timely at this stage to reflect on how do we, as a health profession, as a head and neck health profession that we're trying to improve this, actually change the structure and the systems that we have to cater for the needs of Aboriginal patients, of Torres Strait Islander patients, of vulnerable patients, and a big shout out to our rural and regional patients, because I think they're the kind of people who don't get the same treatment as you would in parity. And if you look at those statistics where 42% compared to 7%, that's a huge difference. And the other part of that, which you didn't include in there, is that under the age of 55, that rate actually increases significantly more. So this is another young population that we have. The wonderful thing about Closing the Gap campaign is we're actually living longer, and as we live longer, you're going to see this explode. And it wasn't long ago where cardiovascular disease was our number one killer. It wouldn't surprise me now if cancer's actually taken over as a number one problem for death, the number one problem for burden of disease, and number one problem in general health in our population. I think that's really important to note.
It is my understanding, Kelvin, that there was a recent announcement that cancer had overtaken heart disease as the major killer of Indigenous people in Australia. Can I say to you, what I've tried to do in this series is to focus on examples of good work to try to inspire those who are keen to improve those early diagnosis, survival, and then rehabilitation, so that Indigenous people not just live to 5 years but live beyond with the best quality of life. I want to share examples of good work. Are there examples of Aboriginal controlled services or services using Aboriginal staff or in partnership with mainstream services where you think they are working well with Aboriginal cancer patients, or particularly head and neck if possible?
I think we're not recognising enough the Aboriginal controlled health organisations and the work they do. Our work in the local area is purely determined by how well the community function. And the Aboriginal Medical Services, or AMS as we call them, are the backbone and the life and blood of the access to understanding. One of the biggest issues where we're getting really good innovations and understanding is that translational research that's out coming about these stats that you talk about, and therefore pass it on to the community. And where the really good examples are is that the community understands it and the community embraces it, then we're going to see more action in these areas. The days of this is a problem and we're going to treat you are long gone. It's a management system that we need to make sure that the community are actually leading the way in the research. They're leading the way in the treatment pathways, and they're leading the way in the innovations that we need to do. So locally, we really try and engage our community as much as possible, where groups like this are really important in that area to make sure that there's a strong voice to say, this is what happened to me.
Just following up in relation to that whole of community approach with Aboriginal communities, I was thinking we would call this particular video, this interview with you, Kelvin, patient, family and community in the title, because it strikes me that with the non-Aboriginal population, one of the recommendations for future work to improve earlier referral to an ear, nose and throat doctor, so earlier stage identification and diagnosis, we tend to think of it as education for general practitioners, for then the individual head and neck cancer patient to get referred by the individual GP. And I'm wondering if in the Aboriginal and Torres Strait Islander context, we need to think rather in terms of community and family rather than individual patient. And so the way forward may be more work with the Aboriginal medical services on awareness around head and neck cancer, not simply with drug and alcohol and tobacco, which have in the past, as we know, been the main causes for all of the whole population, but with this new rising human papillomavirus related throat cancers. So my question is, do we need a community approach with Aboriginal and Torres Strait Islander people that is specific to the community if we're going to improve that data?
Oh, absolutely. I think you sum it up quite nicely, because the real issue here is how do we actually get the community on board to acknowledge this? There are a couple of things that there's a bit of noise in the background, and that noise in the background is there are so many other issues that are occurring on our Aboriginal patients. The young, so children particularly, take up a huge proportion of concern and care, and therefore there's a lot of focus on the kids. Employment opportunities, housing, all those kind of things play a big role. So if you've got something niggling in your throat and you've got an unwell kid who needs antibiotics, you've got no money for work, you need to get to work so otherwise you don't get paid, or you're going to get kicked out of your house because you're not going to get rent paid, then a niggly throat becomes the most minor thing that we are worried about in that kind of aspect, and therefore it may represent a later stage of diagnosis and presentation. One of the beautiful things on a positive note is the resilience in Aboriginal communities is amazing. And with the knowledge in the right hands, that you have some elders talking to you, that you have someone that they have a strong link with, that can actually understand that. And that's where you need that identity to be able to say, you know what, that's something easy to get sorted out. Go see the ENT clinic, they'll get it biopsied and sorted out, and you won't have to worry about a thing, and you get back to your job. That's the kind of attitude we need to have around this, and that's where we need to play a lot more focus, rather than waiting for a long period of time where they put it behind, bury it, there's shame with it, worried about losing work, worried about all these other things. And that, you know what, these are problems that we all have, whether you're Aboriginal or not Aboriginal, in general society, and that's the problem that we have. So we need to break those down. And a big part of that then is that, how do we ensure that when we can get that information to the community, that then we provide the pathways and the access about the correct information, seeing the right people and getting it sorted out appropriately. And I think you said it beautifully there, is that again, we're moving away from the days of the general practitioner being that primary steership holder, and it's rather the community with that knowledge base and the Aboriginal medical services that actually say, you know what, get that done, get in here now, I'll get it organised for you, and then you don't have to worry about a thing. It's really changing that and pushing that along.
You know, if I could just share some of the ideas that have been put forward in the other interviews we've been doing about, you know, what can we do to improve early identification and treatment, survival, quality of life for all head and neck cancer patients. Things like turning up to every session of radiation therapy if you're getting it, not missing a single session. Now, transport is a huge thing, as we know in health, in rural and remote, but it also is in outer suburban, which is where a lot of Aboriginal people live in mainstream cities. Secondly, there's been a lot of emphasis on the need for a national network of specialist head and neck cancer nurses, just as we have with breast cancer and prostate cancer. Because when I see that lower survival rate. 71% of non-Aboriginal people make it to 5 years. Only 42% of Aboriginal and Torres Strait Islander people. I'm wondering if they're turning up. Your people are turning up for all those checks. When I was a patient, I had to turn up every 3 months for a couple of years. Well, if you're in rural and remote or outer suburban, there's a lot of travel to get yourself there. And I'm wondering if in a network of specialist nurses, we also need a network of Aboriginal health workers who are briefed and knowledgeable on the head and neck matter to get those numbers to change.
I think 2 points to talk that is that the network of nurses, we need to encourage Aboriginal nurses into this field. We need Aboriginal nurses in here to represent and actually take the lead in a lot of this, because that'll make a big difference. We need to obviously engage the health workers because they provide such a huge role, but there is so much on their plate that, again, when they've got multiple priorities, head and neck cancer becomes a smaller priority. So why not let's chase with the Aboriginal, the CATSINAM network, which is the Congress of Aboriginal and Torres Strait Islander Nurses, to actually engage more nurses, say this is an area we need you to work in. The other part of that, which if I can flip it on its head, so to speak, is if you have the people who can't attend appointments, and one of the biggest frustrations I have with data sets in the hospital is what we call the DNA rates, or the do not attend rates. And the do not attend rates are a bad reflection on the hospital. And so we sit in these meetings and say, your DNA rate for this Aboriginal clinic was 50%. Why didn't you actually fix it? They're not coming for treatment, so therefore it's a waste of time. The rebuttal for all that all the time is, what are we doing so wrong that makes so many people not show up, that makes so many people not attend their appointments? And I think some of them articulated there with the travel and the cost with that, but there's a whole lot more behind that just than travel and cost. It's about how appropriate is a service. Is it somewhere where they feel comfortable? Is it culturally safe? Is there something that we can do in surveillance clinics, where we run a head and neck clinic, surveillance clinics, and we run it in AMS? We don't do it in a hospital, we do it at the Aboriginal Medical Service with our ENT head and neck cancer surgeons, so that the patients go to a place that they're comfortable with. We have 120% attendance there. In fact, more people come because they feel more comfortable. So it's not actually just looking at the old, the data sets can be actually quite tricky, because you need to actually understand what they mean. And by understanding what they mean, you can change the whole way in which people present and how they attend.
That's very interesting, because I've been to Albury-Wodonga on the border of New South Wales and Victoria with a local Aboriginal woman who's had a head and neck cancer. She did an art exhibition decorating the radiation mask, and I was an MC of a fundraiser there with her. And we went that day to the Albury-Wodonga Cancer Centre, where people could not have been more friendly, but it was a very fellow patient, who was an Aboriginal woman, was manifestly less comfortable in a more flashy, if I could put it that way, clinical environment. We then travelled across town to the Aboriginal Health Service, and she immediately went into a kitchen and made me a cup of tea. There were dental appointments that you could have there, and that was all advertised at the desk. She just related to it as if I'd gone into her house. Now, I'm not actually meaning to criticise Albury-Wodonga Cancer Centre. It was just a really noticeable difference of level of ease. So what can mainstream services do to help bring that ease? Do you know, have you got any examples there?
It's all about self-reflection, and it's a really hard thing to do, because it's actually admitting that your service is not providing for the community that it's looking after. And as a clinician, you've been quite offended. I've got the guys here today in our new flash rooms, and it looks wonderful, but sometimes it's about how you make that environment a lot more comfortable for the patients to appreciate and understand. And we all know that feeling, and people find it hard to struggle. But if you're in, say, overseas in a non-English speaking country and you're unwell in the emergency department of that hospital, if you hear that Aussie twang or an Aussie accent, your eyes light up, you look straight for that corner, you go try and find them, and you may not know, they might be from Perth or somewhere as ghastly as Melbourne, and you actually relate to them straight away, and you want to have that conversation link with them. And that's very much with Aboriginal people. We're such a diverse culture, yet we'll always look out for each other because we know we're comfortable in those roles. And I think if I can explain, I'm trying to think of a nice way to explain implicit bias in what we have. And I was talking to a friend in America, and so this is a story reflected together, where I think I'm very non-sexist, yet in my bias, I think in my unconscious bias it is, I was on the plane going to America and there was a female pilot on a long haul. And I thought, this is fantastic, power to women, all great. How great is this? Hit a bit of turbulence, I'm going, oh, I hope she doesn't drive like a woman. And in my immediate mind, it was just the reflection, whereas if I'm on a plane with a pilot who's a male, I would never have thought that. Yeah. But it was important for me to be able to reflect on myself and think, hang on a sec, why do I have that bias? Why is that bias there? And it's okay to have a bias, but as long as you actually understand that your bias is out of character and not based on any truth in it. And I think for us in our clinics then, it's saying, you know what? Our clinics aren't really prepared for patients who are vulnerable, who are non-English speaking, who are Aboriginal, who are all these other different things that are vulnerable, need that help. And we need to make sure we create that environment where they do that. So for us here, we make sure there's lots of artwork, which is so, I guess, a bit outdated now in that sense, but the fact that we have staff who can relate, that people understand rural, regional, we have Aboriginal, we have all different diverse backgrounds, and it's really important for us to make sure that we can relate somewhere, that someone can see something, and also that we as a group are continually reflecting on how we can actually improve ourselves.
Okay, so non-defensive self-reflection of the team and engagement with local Aboriginal people and organisations.
Non-defensive, critical reflection. It's really important to be harsh on yourself and be able to absorb some of that to say, you know what, maybe that is like that. And sometimes you might disagree, that's okay, but you still need to be able to reflect on those things. So the DNA is one of the really good ones. When you talk to the managers in the hospitals about how they have the DNAs and the way they treat that, it's really eye-opening to watch the faces in the rooms and say, well, why are we doing such a poor job? If you opened up a shoe shop and it was the most amazing shoe shop in the world and no one came into it, you're not going to sit out the front and blame everyone for not coming to the shoe shop. You're actually going to work out, what have I done so badly where people don't want to come to the shop and buy stuff? And this is what we're trying to do in that kind of, I guess it's a client thing. It is a patient ratio, but it's making sure people are welcome, making sure people know where to go to, making sure people are familiar. And as a head and neck cancer patient, when you're going to hospital so much, you should not feel like a visitor there. You should be part of the family there. And how do we create that environment there?
One example, because I love practical examples, I'll share one with you, and if you have another one, I'd be grateful. But when I was a patient in 2013 with stage 4 cancer in the tonsils, tongue and throat, I had 30 consecutive days of radiation and weekly chemo. And I don't know if this is still happening at St Vincent's, but where I was sitting in St Vincent's, a number of what you might call, there were homeless patients, there were some Aboriginal patients, and there were some patients with mental health issues, so very obviously vulnerable patients. And there was a social justice program, and there was a series of volunteers who went and picked up the patient and brought them to the radiation and sat with them and then took them home. Now, I don't know if that's still working, but it struck me as an incredibly practical way of ensuring vulnerable people got that consistent 30-day radiation treatment that was utterly critical. Have you ever seen any other suggestions like that where you've, to help with that consistent follow-up both in treatment but the checking after that's so crucial to catch recurrence early?
It's funny you say that because I think most of my experience in people that have good outcomes and had a good relationship are always based on personal relationships within the facility or within the treatment area. So whether it's that CNC, that special nurse that's looking after, whether it's the same face you see on the front desk when you go in there, whether it's that the wardsman who comes in always says g'day with a smile, whether it's the community person that drops you in. There are plenty of community services that do that kind of travel stuff, but it's that familiarity of being able to feel part of the team in taking your treatment journey. The journey that you're going on through cancer treatment is your own journey and everyone else is on that. And I think sometimes we feel like it's a hospital machinery and you're just coming in as part of that number. And I think the more we can try and personalise that, the better. Which comes back to why it's so important to have these head and neck clinic nurses whose value you could not pay for in their kind of follow-up, their care, their empathy, which makes a huge difference, not only for the journey as an individual going through, but as cancer survival and also cancer tolerance, if I can use that word, and that is all the other things that go with it, the emotional roller coaster you go on, the family dynamics that go on, the employment prospects, the income prospects, all those kind of things that play such a huge role, yet we focus on radiation, chemotherapy, surgery. And we forget about all the other things. So I'll come back to, were really important for us to bookend. And one of the lovely things that we're happy to share all the time is in Aboriginal culture, we talk about that spiritual, cultural, emotional, and physical well-being. And that is truly the pathway for cancer patients. How do we book in all those services, bring the family on the journey to make sure that's good? And the other part of that is demystifying it for the larger family at home. If you're going through treatment, it's not contagious. You can give a cuddle. You can understand what you're going through. This is why I'm going to be a bit sad. This is why I'm a bit tired and lethargic. And I think none of that is actually explained. And when you've gone through that treatment, as I'm sure you're aware, when you're asked 1 or 2 times, you don't mind. When you're asked for the 50th time by someone who's maybe 2, 3 people removed from you, you kind of roll your eyes up and think, oh, I've had enough of this. Yet people go through this every day. So how do we as a profession then have the websites with the information that we can find that information? How do we put it in a medium that people understand? So are there mediums where there's cartoons, YouTube, digestible formats, these kind of conversations where people look and go, you know what, you're all right, this conversation is good. Even hearing the stuff we're talking about today makes people realise there is such a great committed group of people behind this that are looking for ideas, that we're happy to engage in those ideas, but also that we're always looking to how we can improve this journey. And it's not just about treating a disease, it's about looking after a person.
You've touched on something I wanted to raise with you there, and that is that question of literacy and health literacy. And to me, because traditionally head and neck cancer patients have been heavy drinkers or smokers, and I'll come to HPV with my last question in a moment, but it's increasingly it's been traditionally more men than women, and a more working class, lower socioeconomic group of people who get head and neck cancer. And many Australians can't read or write reliably. And while there is a brilliant website that we're promoting on this series of videos run by Beyond 5, so beyond5.org.au, and we've got links on the YouTube site where a lot of people will be watching this. And it's a brilliant website. It has diagrams and it has videos, but the level of literacy required is pretty high. And I'd like to see a lot more materials made, not just for Aboriginal and Torres Strait Islander people, but that very big proportion of people for whom English isn't their first language, or they are Anglo-Australians, but they just haven't learned to read and write. We need a lot more visual material for the head and neck cancer patient. Would you agree, Kelvin?
Absolutely. I think that's so important. I think the other part of that is that it's really important for the people going through treatment to understand it, but it's really important for the wider community to understand this that they're going through. And I also think I get so frustrated with the blame game and the negative connotations with the alcohol and smoking, is that this is a lifestyle that wasn't pushed upon, but that wasn't accepted by them, rather pushed on from circumstance or whatever reason. We don't know that background. And 99.9% of my patients with head and neck cancer are the most beautiful people, and the lovely thing is they all love a yarn because they're used to having a good yarn. They're always smiling and so positive. And we're treating a patient, and come back to that. And so, the notion of, they're smokers, they're drinkers, they deserve it. We've got to get rid of that out of the vocabulary altogether, not even talk about it. And when we do that and take away from the blame game, then we'll get better outcomes. And you look at with the many other disease processes. When HIV was first diagnosed in Sydney, the connotations, the stereotypes were just absolutely appalling. And as soon as we got rid of that, look at the treatment and the kind of survival rates we're getting now, it's fabulous. And that's the way we should be treating health. Health is a human right, no matter what your background is, no matter what circumstance you've found yourself in. How do we get back to being back in that positive strain to get people through this?
You've raised an issue there that segues great into my final point, and that is looking at the human papillomavirus, the HPV, because it's my understanding that the rate of head and neck cancers caused by the human papillomavirus, HPV, is increasing rapidly, and there are now more HPV-related head and neck cancers in the United States than cervical cancers. And it's predominantly because of oral sex. Now, why I raise this is that, are there particular sensitivities in the Aboriginal and Torres Strait Islander community about talking about oral sex? It's hard enough in the mainstream community.
I think in saying that, there's sensitivities in any culture raising those kind of taboo topics. But the the important part of it is that we need to talk about these taboo topics, but we need to find a medium to talk about that. So in women's business, in men's business, we need to bring them up in a very sensitive manner to talk about that. There's been some wonderful work in the Central Australia around STDs with some of our amazing Aboriginal researchers, and to get big randomised control studies looking at that was incredible. And that journey in getting that research was a really powerful journey, and I think I reflect on some of those kind of conversations because that must have been so hard to get that data, that we need to replicate that and bring it into the community, and actually benefits all of us in understanding this process. Absolutely, we need to break down those taboos, and as health professionals we should be able to bring it up without having those kind of connotations or the stigma that goes on with it, because again, going back to what we were saying before, it is so important to be non-judgmental in this area, and more so than ever, particularly with HPV, the outcomes are absolutely superb. So you can get a cancer and present with something that looks absolutely horrific, but the treatment paradigms we have for it show survival rates to be amazing, which is wonderful. So this should be celebrated.
Well, look, is there anything else you'd like to add, Kelvin? Thank you so much. We, just very much wanted to raise awareness of the higher rate of incidence and the poorer outcomes for Indigenous people. Is there any other issue you'd like to raise?
Yeah, I think I've touched on it before. The only thing I'd really like to leave as a message to people listening to this is to be strong and be supportive of each other. But the most important thing is, as a healthcare professional, more than the patients, how do I change my environment and how do I use my spheres of influence to make sure all my patients, most particularly our Aboriginal and Torres Strait Islander patients and vulnerable patients, get looked after equally? And that's challenging because equally doesn't mean the same treatment.
Look, thank you so much, and I'd like, on behalf of everyone watching, to thank Associate Professor Kelvin Kong, an ear, nose and throat surgeon working in Newcastle, and this has been part of a series of videos hosted by St Vincent's Hospital Sydney and the Kinghorn Cancer Centre, looking at innovations to improve survival and quality of life. And if you've got any questions, you can go to the information and support line that's run by Cancer Council, 13 11 20, and they can refer you on to other services, including Indigenous services. And another great source of information is the Beyond 5 website, www.beyond5.org.au. Thank you so much for taking an interest in head and neck cancer and the particular challenges for Aboriginal and Torres Strait Islander people.
Head and neck cancer treatment innovations, improving survival and quality of life, providing up-to-date evidence-based information for everyone in the head and neck cancer community. Presented by Julie McCrossin, a head and neck cancer survivor. Media production by Daniel Taylor at Inside IT. Celebrating World Head and Neck Cancer Day, 27th of July, 2020. Innovations in surgery, radiation therapy, chemotherapy, immunotherapy, dental care, managing distress and recovery, managing mask anxiety, remove the mask research, Aboriginal and Torres Strait Islander patients, family and community. Discussions of innovations that are improving survival and quality of life for patients with head and neck cancers. The 2020 Head and Neck Cancer video series. Presented by St Vincent's Hospital Sydney, the Kinghorn Cancer Centre and St Vincent's Private Hospital Sydney.